All right. So hi, everybody who is joining us live on Facebook. We're going to do a quick introduction of ourselves. I see our numbers are going really fast. We're already at 8, 10. Numbers are going up. I'm Elvia Fisher Meir, the owner of CityKids. And we'll just go quickly introducing ourselves, but I just want to tell you guys a little bit about CityKids before we get started. So CityKids is an English-speaking community center based in central Tel Aviv. We just celebrated in December our 10th birthday, and we've been offering all sorts of high-quality programming over the last decade, whether it's our nursery school program, after-school programs, camps, and Saronim. We have, in a non-COVID year, tons of parenting workshops that we offer about everything related to parenting and living in Israel. Due to COVID, we moved all of our programs virtual. So actually, we're really excited to be able to offer such an important event tonight with our expert panel. But all of our English programs and activities are online, which have been really, really special for us because we have families that don't necessarily live in Tel Aviv and didn't have access to our activities. But now all of a sudden, we have got kids enrolled in our English program from all over the country. So without further ado, I'm going to introduce Taylor, and then we will get to know our expert panel.
Hi, my name is Taylor. I've been working at CityKids for 7 years now. I'm currently the program director, so I'm in charge of all of the parenting workshops, the workshops for children, the English program, camps, things like that. So together with Elvia, we invited our 3 experts tonight for this amazing panel discussion to help not just us as a community, but everyone out there really understand what is happening in the world, vaccinations, mask wearing, and everything like that. So welcome. Thank you for coming and thank you for joining us.
So before we introduce the panel, everybody just said, you know, how did you guys hear about us? And I think one of the jokes that I make is if I was smart enough 10 years ago, I would have just created a Facebook group, but I didn't think of that. I thought about going through the burden of creating a physical space. But we're lucky in Tel Aviv to have a really awesome support group. And there was there was a post on the page, and I saw Joel's response, which really warmed my heart. I think he warmed the hearts of a lot of people that read his post. And then I ended up going down the Joel Kaye rabbit hole, which led me to his Facebook page and his YouTube channel, where I saw him and Avraham doing a workshop a week ago, 10 days ago, that I just thought is, you know, obviously relevant more now than ever, especially with our return to school tomorrow, or our not quite yet return to school tomorrow, depending on if you live in a yellow zone or an orange zone or a red zone. And so Joel, you can introduce yourself first, and then introduce your 2 colleagues that you thought would also be important representatives here.
So thank you. I don't know how I got to be a rabbit hole, but okay. I'm Joel Kaye. I am an immunologist. I have a PhD in immunology from the Weizmann Institute of Science. I then did a fellowship in transplantation immunology at Harvard Medical School. And then we came back to Israel. And for 16 years, I've been working in pharma, developing drugs for autoimmune disease and cancer. And that's what I do during my day job, and the rest of the time I tend to get into fights on Facebook, but that's a whole different hobby.
Like Facebook warriors.
Yeah. Well, yeah. And so Taylor contacted me a couple of days ago, and I actually thought that Noah would be an excellent person to have on board. And without Avraham, there wouldn't be the YouTube channel or the videos or any of the rabbit holes. So Avraham is here as well, and I'll let them introduce themselves. Noah, go for it.
So by profession, I guess I'm a nurse. I have a degree in biology, studied law. I actually did patent law for a year, Avraham. And I worked in bioengineering, patent law, but then I decided I really wanted to become a nurse. So I've been a nurse for 15 years, and I have been a Tipat Chalav nurse. I've been a community nurse. And for the past 5 years, I've been working for Terem, where I'm the actual regional director of Jerusalem, all the clinics in Jerusalem. And I am the director of Corona, which is a very exciting job for everybody there. And I always say I use all those different backgrounds, the biology, the nursing, the law, the everything, to be able to explain science in regular terms. And that's my secret power.
Okay, I'm Avraham Hermon. My background is chemistry. My job is a patent attorney. I'm a U.S. patent agent and an Israeli patent attorney. And I've been working in the pharma field since 2003, starting off my career at Teva, which is where I met Joel, managing Teva's innovative patent portfolio. From there, I moved on to a patent firm, and I now am a partner in a patent firm known as J&B Davis Ben David in Jerusalem. And I deal mainly with clients in the fields of pharmaceuticals and medical cannabis. In terms of my connection to Corona, about 2 months ago, I decided to start a YouTube channel. And the YouTube channel is dedicated to videos having to do with facts and fiction about COVID. COVID-19 facts and fiction, it's called. And we're really focused on, we put out English language videos and focus on trying to bring people accurate information, because over the years, I've seen that when it comes to some medical issues, there's a lot of misinformation or even disinformation. Disinformation is when it's distributed intentionally. And I guess a little bit like what Noah said, my job involves taking complicated concepts and being able to break them down and explain them. And that's really my connection here, that hopefully I'll be able to help with that a bit. And I'm looking forward to this discussion and meeting the community.
Thank you. All right, so I'm going to get started with our first question. It's basic, maybe not basic, we'll find out. So although we all have been going through this COVID or living in this COVID world for about a year now, which is crazy that we're approaching a year in March here in Israel, can you briefly explain what it is that we're actually being exposed to and why it's so contagious? Or in other words, why is it being taken more seriously than the flu or other communicable diseases that we know about?
I'll let Noah take that one.
All right.
So, I mean, what we're actually seeing is, we call it the novel coronavirus, right? Coronaviruses are a family of viruses. And corona is simply from the Latin word for crown. I always like to tell people, especially if this is a kids or a parenting thing, you know, I remind them about Frozen, and it's coronation day, right? She gets her crown. So corona, that's the word. And the reason it's scary is because it's new, and we didn't know necessarily what it was capable of. And as we did start to see that what it was capable of, we realized it was contagious, that it passed in droplets. These were things that we didn't necessarily know a year ago. There were, you know, a lot of things. We're always in this process of learning new things along the way. And we learned what it was capable of. We're still learning what it's capable of in terms of long-term side effects. And we don't really have any medication that works against it. There's always promising things, and we're in phase 2, phase 3. And it is just something that's new and unpredictable, fairly contagious, not necessarily as contagious as, let's say, measles. Measles is much more contagious, for example, but it is scary because it's new and we don't know what it's capable of. And as we see, it continues to mutate and create new variants which maybe we'll discuss later, the idea of mutations and variants. But, you know, as it changes and transmits and changes, we're learning more things that it's capable of. It's capable of becoming more contagious. It's capable of attacking smaller people and children as opposed to the elderly. So this is why it's scary, I think, because it's new and it's really got the perfect storm in terms of being contagious. It's got a reasonably long incubation period, and illnesses, for example, viruses that make you sick immediately when you're contagious, and they make you really, really sick right away, are not viruses that are going to do a very good job. If you look at like Ebola, for example, right? Ebola is a virus that very quickly you get very sick. And what happens is the virus can't do its job, which is simply to make copies of itself. That's all virus really wants to do. And if you get sick and you die, you're not going to pass it along to everybody else and you're gone. So this is why we're sort of worried about this virus.
Great, thank you.
I want to keep reminding everybody who's live on our Facebook page that if you have any questions that come up for yourselves, chances are somebody else has the same question. Although we've prepared questions, feel free to write things in the chat, and we will do our best to answer everything by the time that we're finished with this. So I think now that Noah's given us a little bit of the background of COVID and why it's a little bit different than other diseases, I think it's important to ask the question about the mutations. What's different now that we have the British, South African, Californian mutation? What does that mean? Figuring that we know that that's the purpose of a virus, to mutate, and why is it more scary with these mutations than, you know, in a different virus?
I'll start. I'll start and I'll let Noah jump in at some point if needed. So I'm going to break it down to 3 bits. Let's talk about mutations and viruses. Viruses mutate, that's what they do. Some viruses, like the flu, mutate very, very quickly to the point that we need a vaccine every year because there's new strains. And each vaccine that we get every year is a mixture of strains that were detected. We're in Israel, so they're in the Southern Hemisphere, and then we've got time to make the new vaccines. Some vaccines, I keep doing it. Some viruses mutate very, very slowly. Some don't mutate at all. If you think about the childhood vaccines, measles, mumps, rubella, all of the classic ones, there's no new ones that are made. You don't need a yearly boost. Those are lifelong or very long effect vaccines. So when we get to COVID, some viruses like the flu mutate very, very quickly. Or very long.
Close yourself on the Facebook page.
Close myself on the face. So when we get to COVID, some viruses like the flu
Interesting echo.
mutate very, very quickly.
If you close yourself on the Facebook page, we'll be less. Close yourself on the Facebook page.
Close myself on the face. So when we get to COVID,
I
said there was a Joel K rabbit hole. That's it right there. I closed
It's very
it, so
meta. It's like meta Joel. Yeah, okay.
Hopefully that's done with. So when it comes to COVID, mutations have been detected because as the virus propagates and moves around, it mutates. Nobody actually knows right now the rate of mutation and if the rate of mutation is going to be more like flu or it's a lot less or a bit less. That's what's being tracked over time. Having said that, we need to understand the mutations that are around. So there's the UK variant, the South African variant, the Brazilian variant, etc. These variants, on the one hand, seem to be more virulent. What does that mean? They are a bit more contagious. And the very fact that they are more contagious probably means more people are going to get it. And we already know, as Noah said, that COVID can give severe disease. So if it's more contagious, there is a chance it could be a lot more dangerous. That's on the one hand. On the other hand, the Pfizer and Moderna vaccines, and those are the only vaccines that are in Israel, and we should really focus on those because we're here. Both Pfizer and Moderna have done the experiments and have shown that the antibodies that are made as a result of the vaccine still work against those variants. So although the cases are going up and younger people are getting it probably as a result of the variant, the UK variant more specifically, the vaccines still seem to be protective, and that would be a further incentive to go and get vaccinated, if anything. Just as the flip side, and as an example, the UK vaccine, the AstraZeneca Oxford vaccine, which everyone was very excited about, does not work against the variants, as an example. So not all vaccines are going to work against the variants. There might be new variants that'll come out, and then Pfizer and Moderna will have to test them. And then the next question that I assume someone will ask is, so what happens if there's a variant that comes along that is resistant to the antibodies made by the vaccine? And that's where the beauty of Pfizer and Moderna's technology comes in, because once they know what the variant is, they can just make a new vaccine very quickly. It can be tested pretty quickly. And then if it were to reach the stage that it's like the flu vaccine, we need a new one every year, that I guess you could call that the worst case scenario. I don't know if it is the worst case scenario, but that's what it would be.
If I can add in a second. A few weeks ago, there was talk here in Israel about an Israel variant, and news outlets were talking about a potential Israeli variant. And I think that was more of just sort of a hypothesis that this may happen. We don't know what's going to happen. There's no Israeli variant for real, but people were talking about the possibility that this can exist, and that there are conditions with, if there's a vaccinated population and a non-vaccinated population, that this may happen. We can't predict that in advance. And I think that we have enough to worry about right now without worrying about the possibility of an Israeli variant.
Okay, so I'm going to take a really, go.
I just want to add one thing that I think is an important thing for people to understand, is that we say that a virus mutates and that's its job. Its job is actually to replicate. It's to make copies of itself. But as it replicates, that's where these mutations happen, right? Replication is, you're copying something down by hand. Let's say from you're copying your friend's notes, and you make a little mistake as you're copying the note, right? Maybe you write one letter wrong. It doesn't really change the meaning of what you copy down. That's kind of like a little mutation, and your body knows to correct for some of these things sometimes, and the DNA will rewrite itself and copy over these things. But when you get to one that's significant, that changes the meaning of a sentence, that's when you end up with a variant. But how can you prevent, in some ways, right, this from happening? Stop the copying of the notes, right? If you don't copy the notes, then you won't end up with a mistake or writing a word differently. And that copying of the notes is transmitting the virus, right? So any way that we can stop the transmissions, whether that's by vaccinations or masks and social distancing, or both together, right? That will stop the formation of new scary variants. So there is this idea, well, you get vaccinated if you want to, and I'm not going to. But at the end of the day, we are actually all part of the same society. And so if half of us choose to get vaccinated and the other half continue to spread the virus and make new mutations and variants, then eventually my vaccine doesn't work for those variants. So there is this interconnectivity of stopping these transmissions to stop the new variants.
All right. Well, my question was, what do you have to say to people that are on the fence? And I think that's the answer to what do we say about people that are on the fence?
Well, I think there's a lot to be said to people who are on the fence. I'll start, but I think Joel has quite a bit to say too, and maybe Avraham does as well. But the first thing I would say to people on the fence is, like, I hear you, I see you. It's scary, right? This is a scary year, and it's very easy when you're scared. And you hear a lot of noise coming from so many different directions. It's easy, or I don't want to say easy, but your natural inclination is to stop the noise, right? And stop the noise for me is, you know what? I'm not going to get vaccinated right now because there's a lot of noise over here. And I'm afraid of corona maybe, so there's a lot of noise over here. So what I'm just going to do is do nothing for now. And what I want people to understand is that is also a decision. It sounds like what you're doing is stopping the noise, but it's actually also a decision. And that decision allows the virus to continue to transmit and mutate and make variants. So I do understand that a lot of it comes from fear. And that's really what I think all three of us do in our different ways, right? I have a page, also Nurse Noah, and I explain these things because you have to be able to make decisions and understand from a place of less fear, or you won't, facts are not something that can really balance against fear. Fear is a very powerful emotion. And so I can give you all the dry facts in the world, but at the end of the day, the emotion will always win. And so my job is to try and reduce the fear by giving you easy information that makes sense, that makes it less scary. So for the fence dwellers, I totally see you. It's a crazy year and it looks like it's gonna be another one. So I get it. All right.
And I'll just add that the other thing that all three of us do and is very important. So my message is that if you are sitting on the fence, Noah sees you and hears you, the only thing that I would ask of you is that choice is yours. That decision is yours. The fear is yours. What we all spend our time fighting against is the spread of the fear. So if you're scared and you're hearing that noise, you don't need to be part of spreading the noise. So if you've heard some fear-mongering fact that you saw in a YouTube video and you send that on, then you become part of the issue at the moment, which is spread in social media of misinformation. And it's not disinformation in most cases. It's disinformation when someone does it on purpose. So hopefully, if you're listening to us and we give you those little bits of facts, it'll help you calm the fear. But my only request is, if you do have that fear, keep it to yourself and don't spread it around.
I have a message to the fence dwellers, and I totally understand that we're living in a difficult time and a confusing time. Let's just take an example from our lives and think about, if we have a problem that has to do with running our business, then what we will probably do is go to an expert who's, let's say maybe an accountant. Okay, he's certified, he studied a lot to learn accounting. If I have a legal problem, I need someone to write up a contract, I'm not going to try to write it by myself. I'm going to go to a person who's an expert who studied law. I think here in this situation, there's a problem, right? There's a disease. We don't know exactly where it came from. It could be what's called zoonosis, that it skipped over from an animal to humans. That's what many of the theories are saying right now. But the question is, who are the experts right now? Are the experts are those the people that studied many years, dedicated their lives to studying viruses, the immune system, possibly people that work in hospitals, that are heads of hospitals? These are the people I think that we should be listening to, people who have spent many years studying this topic, preparing for this, and understanding the systems that are in play here, the hospitals, the medical system, and the pharmaceutical companies, how the pharmaceutical companies work. That's one point. Another point is that sometimes people try to come up with these elaborate ideas and schemes of, they're trying to make money, and that's why there's this pandemic, or that's why there's this vaccine. It's just an effort to make money. And I think that I can speak for myself and also for Joel. Working in a pharmaceutical company, it's a huge organization. Pfizer has, I believe, hundreds of thousands of employees, one of the biggest pharmaceutical companies in the world. If they're just doing it for the money and trying to trick us, I think that we would have heard about it by now. Not only that, there are a bunch of competing companies that are making similar products, like Pfizer and Moderna, RNA vaccines. And how is it possible that they're all in cahoots? They're competitors. They're not working. They usually don't work together. Why would they work together to try to trick the whole world? I think it's hard to swallow those sort of theories. And that's why I think we have to go back to the first point, which is, looking at the experts, finding out who the experts are, and trying to figure out what they're saying.
Great, thanks. So our next question is basically about the current recommendations. So what are the current recommendations for children, adults, pregnant and breastfeeding women in terms of getting the vaccine? Who would like to?
I'll start with the children. I'll start with the children, and then
I'm well qualified on pregnant and breastfeeding, so you can start.
Okay.
So the Pfizer and Moderna vaccines are approved. Pfizer from 16 and up, Moderna from 18 and up. Children were not studied in the clinical studies. They are both currently enrolling, or actually Moderna finished enrolling, in 12 to 15-year-olds. That's the next step. When they have that data, they'll probably do under 12. What does that mean? Probably 5 till 12, and then only after that, under 5. So under 12 years old is going to take time. The 12 to 15-year-olds, the data is expected in the summer. This ties into another theme that I should have started with at the beginning. COVID is a disease that's only been around for a year. SARS-CoV-2 is a novel virus, has only been around just over a year. Science has been running along with the virus, and we have learned so much as we're going, but there's still a lot to learn. The vaccine, and we can discuss the approval and the speed that it was developed, which is miraculous in my opinion. The vaccine, there are a lot of open questions that on a daily basis we get answers to. But what I'm trying to say is that we need time and we need data. And so I know that everyone is looking for the answers, but actually the biggest thing that everybody needs is that famous Israeli word, savlanut. And I know it's difficult. We just need to see the data, and that means we have to just wait. And I'll give some examples later on when we get to talk about the effect of the vaccine and the rollout in Israel and things like that. Things have happened very quickly, but when the vaccines first came out, there were lots of questions about, can you still get it? Can you transmit it, etc. And we'll discuss that later. And nobody knew, but we know now because the data is coming out. So that's the children. Pregnancy and breastfeeding, I'll let Noah go, and if there's anything to add, I'll jump in.
Thank you.
With pregnancy and breastfeeding, I'll just add my qualifications here. I am an IBCLC certified lactation consultant, and I was a high-risk obstetrics nurse for 5 years at Hadassah Hospital and an obstetrics nurse for 3 years at Choritz. So for both of these, for pregnant and breastfeeding, we always lump them together. It's actually not exactly the same. I'll start with actually breastfeeding because that's simpler, is that there are, actually for both, I'm going to say, almost no drugs are tested on pregnant and breastfeeding women. This is a category, right? Joel was just describing to you how first they tested 16/18 and above, then they're doing 12 to 15, right? There are levels at how any drug is tested. Pregnant and breastfeeding are almost never tested at all. For example, of all the drugs that were approved in the first decade of this millennium, right, from 2000 to 2010, to date, 2% have been tested on pregnant or breastfeeding women. 98% of the drugs that were developed are never tested. It's a difficult testing process. Ethically, it's sometimes quite difficult to get it passed through the review boards that give ethical approval. In Israel, we call them the Helsinkis, but it's expensive and it's very often just not done. So that's why, for example, when you buy cough drops and it says on it, if you are pregnant or breastfeeding, please ask your doctor. That's because they're just covering their butts because they have never tested anything on pregnant or breastfeeding women. They just don't do it. And some bioethicists will even tell you that not testing on pregnant and breastfeeding women is the ethical problem because you leave a large chunk of women for a large part of their life unable to safely test these things. So for pregnant and breastfeeding, what do we do though, right? We hardly test them. So what we do is we have these categories, and there are 2 different categories. They're very similar for pregnancy and for breastfeeding. In pregnancy, we have A, B, C, D, E, and X, whatever. In breastfeeding, we have L1 through L5. And L1 means it was tested on breastfeeding women and it was seen to be fine. And that I've seen it's hilarious, but it basically includes synthetic thyroid and like unicorn tears. There's really very little in that category because, as I said, less than 2% of the drugs were ever tested on breastfeeding women. So what do? Women end up taking these things anyway, both pregnant and breastfeeding. And we observe and we kind of sort of see what happens. We test on animals and we make leaps from there. And these are how we get to these categories. So for vaccines in breastfeeding women, there are 0 vaccines that are not approved for breastfeeding people, 0. They're all permitted. So it's not likely that this one would also, would not be permitted. Actually, there are very few drugs that are prohibited in breastfeeding. Again, very few are tested, but there are very few that are straight up prohibited. Lithium, some, not even all forms of chemotherapy, but very few drugs are prohibited in breastfeeding. When we get to pregnancy, it's even more complicated, right? Because you can't test the fetus until the fetus is out. So you don't know these long-term effects. And we are, I think as a world at this point, very sensitive to the concept of drugs to pregnant people. However, even for vaccines, there are no vaccines actually that are truly contraindicated in pregnancy. We recommend not to give MMR, but actually there's no scientific data not to give MMR. I can tell you I inadvertently got MMR when I was pregnant. My son's 15, he's doing fine. But not that we use an N of 1 to prove any points. But there's no reason why the vaccine would be problematic in pregnancy if you understand the science of it, which is why the American College of Obstetricians and Gynecologists, the Royal College of Obstetricians and Gynecologists have all said that pregnant women can get the vaccine. Now, what does can get mean? Everything is a risk-benefit analysis, right? This is true of all of medicine. Every time I trying to help a patient make a decision, I'm trying to help them balance the options and what is the cost of not doing this versus the cost of doing this. And so for a pregnant person, you have to look at their risk benefit analysis, and it's different for each person. Again, we don't think there's going to be anything wrong with the vaccine. The opposite. We now know that in this variant, for example, pregnant women are really attacked by the virus and are doing far more poorly when you compare them to women of the same age who are not pregnant. So you have to have this risk-benefit analysis. So, if you have a woman who lives alone at home by herself and it doesn't go out to work and doesn't have any other children who are going out to GON, you might make a risk-benefit analysis that for this specific person, avoiding the vaccine for now is not unreasonable. But if you are a healthcare worker, you have other children who go to school, you live your life, and we know that the British variant, for example, is far more problematic for pregnant women, then you make a different risk-benefit analysis. Nobody's out there saying, we will swear on a book that this is 100% safe. What we're saying is the cost of not doing is actually higher than the cost of doing, as far as we know. And I think only somebody who truly understands the risks and the benefits for each person can make that decision. And the decision that's right for you, Taylor, is not going to be right for you, Elvia, necessarily, because you're different people and you have different backgrounds. So that's about pregnant and breastfeeding.
And I just want to add 2 things from the science side. So let's just remember the vaccine gets injected into your muscle, right? The mRNA. The mRNA gets degraded within hours to days. It does not reach circulation. It's never going to go to the placenta. It's never going to go to the brain. It's never going to go to your testes. It's not going to go to your liver. All right. It's a local injection and it's a local effect of the immune system. It's the immune system that then kicks in and does the work. That's the one side. The other thing that people have heard is that the immune system is now going to recognize the placenta and it's going to recognize the testes, and I'm going to have an autoimmune reaction that's going to cause my baby to have damage, or I'm going to have an abortion, or I'm never going to have children. There is zero, not even a little bit. There is zero scientific basis to the claim. Somebody who made the claim said that the spike protein of the virus is very similar to a placental protein. It's not how the immune system works.
No. Oh my God.
What happened there, Olivia?
Sorry. I'm just like, I own a gun, and all of the gun owners in Tel Aviv are freaking out right now. So I just asked my husband to check.
So scientifically, there is zero risk. And the risk benefit that Noah mentioned before, I think that's more important. This variant is affecting pregnant women. Misrad Briut made a very clear risk benefit analysis. And they said the following: Pfizer and Moderna didn't study it in pregnant women. We don't know what's going to happen in pregnant women, but pregnant women compared to age-matched non-pregnant women are getting much sicker, and the risk is too great. So we're going to trust that women of that age were tested by Pfizer and Moderna. They weren't pregnant. We're going to trust that 55 million people around the world have already gotten the vaccine. And we're going to recommend, because we don't want pregnant women to land up in hospital and have complications of COVID, we're going to take the decision for you. And we're going to recommend that you get it during pregnancy.
If I can add on to what Joel said also, regarding not seeing any risk in vaccination. I think one of the claims that Joel mentioned was the fact that antibodies that are generated against the spike protein will impact this specific protein that's involved in development of placenta and will cause abortions. And according to that reasoning, we understand that if someone is infected with COVID, they should also be, their immune system will be generating antibodies to various parts of the COVID virus, including the spike protein. And if those antibodies are in fact present in COVID patients, then we should see among women who are at very early stages of pregnancy some sort of impact of COVID on rates of abortion. And that hasn't been seen as far as we know. So that same claim that antibodies against the spike protein are going to impact fertility and are going to cause early abortions doesn't seem to make a lot of sense because of what we didn't see with regard to COVID itself.
All right, we're going to ask two more questions about general vaccines before we segue into COVID and kids. The first question is, how quickly after immunization does the vaccine protect the recipient, and how long is immunity lasting?
How big is your crystal ball, right?
Mm-hmm. So let's focus on Pfizer and Moderna again. You get 2 shots. Pfizer's day 1 and day 21, Moderna day 1 and day 28. The reason there's 2 shots. The first shot, what happens is, as I said, the vaccine gets into your muscle. The mRNA makes the protein of the spike protein of the virus, and it goes and sits on the outside of the cells and it waves to the immune system. It says, come and get me. That's the first time. And the immune system starts to work. The second time is a booster, because what you want to do is to make memory. And that's how immunity works to all bugs, all vaccines, all bacteria, all antigens. If you've got an allergy, it's all the same. You have cells running around your bodies that are called memory cells, different types of immune cells, B cells, T cells. But they are called memory because they have memory. What does that mean? They hang around forever. And in a year or 5 years or 10 years, if it meets the virus again, it remembers it, it blows out and expands very quickly to deal with the virus. So it's those memory cells that you want. And to answer the question, 7 days after the second shot, we know that you're immune. You've got enough antibodies that can neutralize the virus. But that doesn't mean it hasn't started working already from the first shot. So lots of data is coming out of Israel showing the number of hospitalizations and the number of serious cases are already going down after the first shot. The number of people in hospital that got the virus after the second shot is minuscule and have much milder disease. So it's happening probably within 12 days from the first shot, but to be fully buffered, let's say 7 days after the second shot. Now, how long does it last for? Noah said it's a crystal ball. So what do we know? There has been very recent publications showing from coronavirus, people that got it and got better, up until 8 months out, which is where they've tracked so far, they've still got immunity. Now, in theory, the immunity by vaccine or by vaccination is going to be better than natural infection, but that still needs to be shown. So we base our understanding on what happens to the natural infection. So if it can last for 8 months by natural infection, it'll happen for vaccination as well. The reason the famous green passport or the certificate or whatever you got after your 2 shots has got a date on it 6 months from the date of the second shot is because you can only base on the data that you have, which shows 6 to 8 months after infection, you still have immunity. So they put a date on it. That doesn't mean after 6 months, it won't be protective. And in 6 months' time, once there's more data, because we'll have data over a year, I would imagine, if I'm going to be a betting man and put money down, that Mr. Adabrio will just extend it for another 6 months until they have more data. But all we know right now is 8 months, because that's the time that we have.
I'm going to add one other element of the crystal ball that I think is a great thing, which is the original study members from the Pfizer and Moderna studies, certainly Pfizer, they continue to be tested. They are tested, some of them on a weekly basis, to see their antibody levels, and they're also given nasal swabs and PCR tests. So we actually do have a bit of a crystal ball, because if you know, these study members were, their studies commenced in April, May, June, July, right? That's when they got their vaccines. So we know what's happening with them. And that gives us like a 6-month window into the future, because they got their vaccines a good 6 months before the rest of us did, and they continue to be tested. So we don't know how long it's going to last, because as Joel has mentioned, we are in the middle of the science, but we do have this crystal ball 6 months into the future, because we know what happens to the original study members, and they all got their vaccines before us, and we continue to test them. So it actually gives us a bit of a buffer. Whereas, like, if it's going to run out, if we're going to need a booster, we have that 6-month buffer to create it and distribute it again, because we know what's happening based on the people in that study.
So Moderna published today in the New England Journal of Medicine their follow-up study on the initial phase 1 patients. So their original publication in the New England Journal was 30 or 40 days after the second shot. Today's data is 119 days after the 90 days after the second shot, 119 days from the first. And they show that the antibodies level dropped a little bit, but they're still way above what is expected that's needed to provide immunity. So it took 4 months for them to gather the data and publish the data. So in 4 months' time, there'll be more. But they are tracking and publishing, and that's how we learn.
I want to ask, just because you said it, Joel, and then Taylor will move into COVID and children. So you mentioned about people who've recovered from COVID. So we know that in the US, people who've recovered from COVID are already eligible from the vaccine. Is Israel expected to start vaccinating those who've recovered from COVID?
So this is public policy and less science. The public policy was very clear. They said at the beginning, we don't know how many vaccines we're going to get. We have to prioritize. So they started with 80 and above, then they went 60 and above, and then they started lowering it. And they said at the bottom of the line at the moment are people that got corona and recovered because they're naturally immune. But we see that there's plenty of vaccines out there. The government went bought enough for everyone. So I believe it's just a matter of time until policy changes. They will allow people that got it and recovered to get it. There's no scientific reason not to. There's no risk, by the way. You'll hear people saying, if I got it and recovered and I get the vaccine, my reaction is going to be much worse, or I'm going to have an autoimmune disease or whatever it may be. There's no basis to that either. There's no risk in getting it. It shouldn't be misinterpreted as a risk. It was stratification based on policy. And policy is made by government, and some of us like the government and some of us don't, and some of us like it yesterday and don't like it today. So I'll stay out of policy and stay in science.
I do see quite a bit of policy because I am the director of stuff. So I get like a lot of these policy decisions before they're implemented. And I see there's usually a pattern that they follow in terms of like protocols that they send out before they start changing things. And I would imagine it's not very far off that they're going to start authorizing the vaccine for people who are recovered. The handwriting on the wall is there. So I think it'll be coming, I would guess, within weeks.
Okay, wait, Taylor, we just got a question, a follow-up question to what Joel was saying. So Sarah writes to us, someone that had corona already, does he really need to have the vaccine, even if the antibodies are not there? Maybe the T cells are already immune to the virus. Will they vaccinate people that already had corona? So.
Yeah, so yes, the person's immune, they've got T cells and B cells. Like I said, it's theoretical that it's more than theory, because this is how it is with vaccines, but not every vaccine is better than natural infection. But the way it was designed with the spike protein and the way that we see the immune system reacting, it's more than likely that immune response to vaccination is better than immune response to infection, but we don't have the data to support that. Yeah, if the government opens it up to people that recovered and they want to go and get it, they should go and get it.
Cool.
So the next question actually comes from one of the parents in our community. So I also want to remind everyone who's watching us on Facebook Live right now to feel free to ask us any questions or submit your questions, and we will be asking as well. This one comes from Lauren. She said, there's been quite a bit of research showing extensive organ damage in people who've had mild cases of COVID-19. Has there been any similar research in children who have recovered, and what is it showing so far?
Question. I'm not familiar with any specific research on children who have, like, let's say, asymptomatic cases. We all know these the multi-system organ failure things that we've been seeing. That's a thing. I don't know of any specific.
I was looking. I haven't seen it. So there's a bit of a black hole when it comes to children, unfortunately.
The breastfeeding mothers. Yeah.
because up until very recently, there were these severe cases that are very symptomatic with multi-organ failure and Kawasaki-like disease in children. But overall, younger people, and I'm not including only children, even in their 20s and 30s, overall, younger people were getting asymptomatic or mild disease. But I think these British and UK mutations have shuffled the cards. And we're seeing, first of all, the average age of severe cases has dropped by several years already in the last couple of weeks. So it was up at 66 and it's down to 60. And that's the average. That means that younger people are getting into the hospital. We're seeing much more severe cases in younger people. I haven't seen, and I was hunting through the Misrad Abreut data, and it's a little bit of a hunt. I haven't seen yet that the number of symptomatic cases in children has gone up. But I don't know if the data is out there to find it. The number of cases hasn't changed. So PCR positive cases of COVID in children, those numbers are still around, and they've even gone up a little bit in the younger people. But like I said, there's a bit of a black hole with the kids, and most of the kids are getting asymptomatic disease. That does not mean that they don't transmit it if they got it. That means they don't have symptoms.
I'll just add also, Joel and I had a Zoom earlier this week, and a physician participated, and he's the director of pediatric gastro in Asuta in Ashdod, and he was telling us about a case of a 16-year-old coming in that was in very bad shape from COVID and almost didn't make it, and they got him hooked up to the ECMO, and luckily he pulled through. But the point being, here, this N is 1 once again, but it's if you consider 16-year-olds children, then there's definitely a risk here.
Just before you dive into more kids questions, I just want to say one more scientific thing. I don't like using the herd immunity thing, but let's call it community immunity. What is the concept of social responsibility in the case? And Noah mentioned it at the very beginning. Look, I'm sticking to Israel again. I'm not talking about the US or the UK or Australia or whatever it may be. The fact on the ground in Israel is 70% of the population is over the age of 16. That means 30% is under the age of 16. So the kids at the moment are not getting the vaccine. Now, what is the purpose of a mass vaccination program? What does it do? What is herd immunity? And I have a nice figure that if we, I'll decide later if we need it, but basically it's a barrier. The virus needs to jump to live. So if I make a barrier by having, let's say, a viral infected person sitting in the middle of a circle and everyone around them is vaccinated, the virus can't jump to the next circle. All right. So we're actually going to protect our kids if all of the adults over the age of 16 go and get vaccinated, because the chances of the virus moving around become much, much, much less. We might not reach the critical mass for zero transmission, but we're going to drop that transmission all the way down. So the responsibility, I think, of the adults, whether they're healthy and they might not get a severe disease, is actually going to be to the older people who've almost all been vaccinated, and to the younger people. And I think that I don't know if everyone understands their social responsibility, but I think that we all have it to everyone. You know, Kol Yisrael Aravim Zeh Lazeh. It's not just a stupid statement. It's true. I mean, I really think that you go and you get the shot, and yes, you might get a sore arm and a headache, and you know, there is a risk that there might be a rare side effect. It's true. Medicines have side effects. But, you know, the greater good is that we'll get back to normal as much as possible, because the kids can't get the vaccine at the moment.
So we have another question from a mom in our community who asked, more children are getting infected now. Are the variants simply more contagious and therefore more of the population, including children, are catching COVID? Or is it genuinely more serious for children? Headlines such as 4 children in Israel die of COVID. Hadassah opens a pediatric COVID unit. Are they sensational news clickbait, or are they worthy of additional concern?
No, there's definite concern. I don't think we know 100%. We know it's more contagious. Is it more dangerous? I think it's more dangerous because it's more contagious. Let's just remember, what does it mean, the variants are in the spike protein. What is the spike protein? The virus binds to something on the cell to get in the cell, and it binds through the spike protein. So these variants make it better at attaching to our cells and getting in. All right, so that's why you're seeing more people getting infected. The virus is better at getting in. That's what these variants do. And I think it's a property of the fact that more people are getting infected that you see more severe cases. It's not that the variants not only get in better, but they're actually more dangerous in their ability to infect and damage. And it's not sensationalism. I mean, there's real issues, and Noah's on the front lines medically. I'm not. I'm sitting in a lab.
We're definitely seeing more children, even with symptoms. They are still mild symptoms, but the children we're seeing far more kids coming in, and kids getting sicker. So is that a function of the variant? I think yes, but you know, we don't see it. You know, you can say it's just more people are getting it, so more people are getting sick, and that includes children as well. But overall, what we are seeing is more young, like the age is totally shifted in terms of who are we seeing that are seriously sick. Avraham mentioned a 16-year-old on ECMO, but you know, in general, we are seeing that with the spread of the British variant, South African variant is not quite as widespread in Israel yet, but it's on its way. It's in community spread already. And I think it is more dangerous to children. There's a reason why Hadassah had to open an ICU specifically for children. And it's because it was needed. And until now, it wasn't really needed. I've seen babies a few weeks old with corona. So I think it is. I don't think it's sensationalist.
So our next question is about mask wearing. I know so should children be wearing masks, and are there situations where children under 5 years old should be wearing masks? What's your opinion on that?
I think all ages that are capable of wearing masks should be wearing masks. I don't think children under the age of 5 cannot wear masks. I think they can. And I have 3 kids myself, although they're older at this point. But one of my youngest is on the autism spectrum, so I'm fully familiar with sensory issues and things like that. I think kids they should be, you know, we in the very, I don't want to say the very beginning, but let's say 6 months ago, we were still under this impression that maybe children didn't transmit the virus in the way that the adults transmitted the virus. We don't think that anymore. But at the time, one of the hunches was that children were generally asymptomatic, meaning they didn't have the coughing and the sneezing. And the coughing and the sneezing is what allows the virus to really be propelled far. And so since children were largely asymptomatic, they didn't necessarily need to have, this was the idea. We don't think that that's the case anymore. And we know that children have the same viral load, right? The same quantity of virus that adults do. So my opinion is that children under age 5 should be wearing masks, because at the moment, particularly now, even let's say in the past few weeks, they are the spreaders, right? What we're seeing is the kids are spreading it and then bringing it home. So I completely understand the idea that children really communicate using facial expressions, and this is really important. But this is also, you know, you can't have everything. If you want to be able to have guns, I think you should be able to implement these things. If you think that it's more important for that then don't have the gun, but also don't have the mask for the kids. Right now we have both, and it's not panning out so well, in my opinion. I'm curious to hear what Joel and Avraham think.
Yeah, I'm staying out of policy.
I could say that I have a number of kids, some of them under the age of 5. And what we've been trying to do as just a practical thing is limit the amount of time spent playing with friends. There's been a lot of play with, luckily, the kids are spaced pretty close to each other. So they have that interaction within the house with the siblings, parents spending a lot of time playing with the kids. And virtual meetings via Zoom. That's what we've been doing in cases where mask wearing is difficult and not touching each other, not coming into contact with each other is difficult at certain ages. This is an alternative, not an ideal, but I think that it's acceptable given the current situation.
Thanks.
That's my non-professional fatherly opinion.
So we have a couple of questions in the chat. We'll get to all of them by the end, but because we're talking about kids right now, Katie's asking, if a child has had corona, is their immunity currently the same length of time of that as an adult, or does it vary for children?
Off the top of my head, I don't see a reason that it would be different. But I don't know if anyone's actually studied that, but no, I don't see a reason it would be different.
I would add only very small children who don't have a fully developed immune system, right? Let's say under 2s, 3s, but beyond that, we consider the immune system fully developed for these kids, right? So
would it make a difference if the child was symptomatic or asymptomatic?
No.
Okay. So we're going to now segue into the return to school.
into policy, Joel, yeah.
If my child's teachers have all been vaccinated, do they still need to wear masks? Which is also a general adult population question.
Your child, the only child in the class?
Wait, so we're talking about very young children, because obviously children over 7 in the public system are wearing masks. We're talking about I guess in the gun age. Should the
So the
teacher,
question was, if the teacher's vaccinated,
yeah,
do they need to
done
wear a
2
mask?
shots and passed the 7 days, should they still be wearing a mask in the classroom?
So I'm saying, unless your kid is alone in the classroom with their teachers, there's still other kids in the classroom. Unless I'm not understanding the question correctly.
The question is if the teacher who's already vaccinated or the group of teachers who are in the classroom are vaccinated, do they need to be wearing masks in the classroom?
The teachers need to be wearing
Teacher.
masks. Oh, okay. I thought you were asking the kids, and I was like, what are they, the only ones there? So now I'm sure there's a science answer. Joel's going to do it. I'm going to give you the policy, the nurse answer here. I'm not speaking biology or anything else. I think there is value in setting a good example for your students. That's my thoughts. But that's not really scientific. Scientifically, I'll let Joel answer the science on that one.
So there's a couple of things. So first of all,
Jill, I'll just say that this answer is going to directly answer Sarah's question in the comment, which is, once you get vaccinated, is it preventing you from getting sick, or is it preventing you from transmitting the virus?
So what does it mean when people hear 95% efficacy? Oh, it works 95%, 92%, 91%. What does that mean, right? It doesn't mean that you are Starship Enterprise and your barriers, your shields are up at 95%. It doesn't mean that. It doesn't mean that you have 95% of your antibodies, okay? It's what they did in the studies was to vaccinate half the people and the other half got placebo. And then they counted how many people got the virus. And then the difference is 95%. So if there's 100 people in placebo, let's say, just for example, just for the example, and there's 100 people who got vaccinated. So 5 out of the 100 might get the virus in the vaccinated group. So there's 95% protection, okay? Bottom line is, if you're vaccinated, you can still get the virus. If you get the virus, more than likely, you'll get a mild version because you've got your antibodies sitting there waiting. But you're not 100% protected. You're not going to walk around and never get the virus. So that's on the one hand. On the other hand, the mask. So at the very beginning, as a scientist that works in a lab, and I know how masks work, and I know how people work, and I know that I touch my face and I touch my glasses, and my mask gets dirty, and I'm wearing gloves, and then I take them off. I thought the masks was a disaster, and there was no reason for it. In fact, I thought it was ridiculous until the data came out and showed that masks, together with social distancing, actually worked. It shut down the ability of the virus to transfer. So I think, never mind setting a good example. If you really want to protect yourself, put on a mask, change the mask, don't touch your face, wash your hands. Unfortunately, we're still living in a pandemic, so we're going to have to keep the rules until more data comes out. Just as an example, the data that came out this week showed, and this is fascinating, that people that got their 2 shots have less, if they get the virus, they have less virus than people that didn't get the shot. They can measure that. When they do the PCR test, that's a surrogate for understanding how much virus, how much load you've got. That's the first time that there's real evidence, right, that you will prevent transmission. Because why are you preventing transmission? If you drop the number of viruses running around your lungs and your nose and your throat, the chance of you coughing and sending it over is less because there's less around. So the vaccine really works. I mean, there's data that's showing real effect of the vaccine. But I think we need to err on the side of caution, and therefore the teacher should probably wear the mask. They could take it off if the kid doesn't understand and put it back on. And like I said, using chad-parmi masks, use as many as you can. I mean, it's not great for the environment, but it's certainly better for you.
I think I mean, again, you're talking to 2 scientists and a nurse. So masks were definitely part of our life well before they were part of yours. but I see them as like this very low cost way of doing, the smart thing, erring on the side of caution. I think for us, it never crossed my mind that masks were a difficult thing. So again, obviously we are all speaking from our experience where we wore masks all the time already. And with that, I do have to add that in my life, I never thought I would have to tell people to cover their nose with a mask. Like when you put it on, it covers both. Like it didn't occur to me that anybody would stick it below their nose. Like why? I walk through my waiting rooms at Terran, right? And I still every day, every time I walk through the waiting room, still have to remind people your nose and your mouth are connected. And I'm like, we are a year into this, people. Your nose and your mouth are still connected. But these were not things that ever occurred that I would think about. But again, I see masks, and everybody sees masks as a really sort of low cost way of contributing correctly and erring on the side of caution.
Great. So we have some questions in the chat. I'm going to say some of these questions have already been answered. So if you missed them, then feel free to come back, and this will live on our Facebook page, and it'll live on Avraham and Joel's YouTube page, or Avraham's YouTube page. So make sure to check those out. I have this, I think, is a policy question. Is the traffic light system effective if teachers and children are coming from different colored zones? Everyone's shaking their head no. What are we supposed to do?
It's like this word capsule. I love the word capsule. I have a son who's in high school. His class was in, for the 3 days they were in school, 4 capsules. He had a capsule for his English classes, a capsule for his math class, a capsule for his general class, and we're religious, so a capsule for his Gemara classes, right? Everything was different. That's no capsule, right? So it's the same thing with the traffic light. If you can contain everything, that's great. But if you live in a green, I live in a town, and my son, I said I have one on the autism spectrum, so he goes to a school in a different district. My town is red, his district is green, and he's allowed to go to school. Who does that help besides me and getting him off to school, right? It doesn't really help anybody. If you are letting people from one color go to work in another and go to school in another, and their parents work in another and they go to school in another, you have nothing. You have nothing.
Policy.
I'll give you 2 stories, all right? Because this really is government and policy, right? It's Yisro bluff, totally. The 2 stories. Story number 1, when before the previous lockdown, when we had at work, I mean, we considered Chioni at work because we developed drugs for cancer. I have a lab. I have 10 people in the lab. I have to be at work. So we didn't want to risk shutting down the lab. So we split the company into two capsules, right? My boss turns up
I love this word capsule. Do they live in the lab? Do they sleep in the lab? That's not a capsule.
Right. My boss turns up on the wrong day, and she's like, oh, I'm already here, so let's just do the meetings. And I sat in meetings with her all day, and she called me that night, and she was like, my brother-in-law and sister-in-law, I had Shabbat lunch with them, and they are both physicians, and they're both positive. 5 days later, she did a test, and she was positive. So I went into Bidud. So it didn't work, bottom line. The other story that I'm going to say, I grew up in Perth, Western Australia, okay? They had 1 case last week. 1 case. They shut 2 million people down for a week. They weren't allowed to leave their houses. 2 million people because there was 1 single case. South Korea, Taiwan, China, Japan, they did contact tracing and they enforced isolation. Australia, they're mad. I mean, 2 million people because of a single case. But that's why they've only got a single case. Because A, people follow the rules, and B, they actually contact trace every single case to find out where it came from, who they were in touch with, and they put them in isolation. It's just never going to work here. It just doesn't work.
I'm going to add also the stoplight system theoretically is a great system, because theoretically what should be happening is those places that have high that are in red towns. I'm in red town right now. Hi. So they should be, you know, my neighbors on all sides were sick. So luckily we didn't get hit. But we should be locked down. You know, we should be like Perth. We should be confined to this place, and I'm willing to pay that price so that economy goes on. I'm fine working from home for a few days. That works for me. But then those people that are green, those green communities, there's very little risk of infection if those people stick to those places. Okay, so it theoretically would work well, but it wasn't, either it wasn't thought out properly or it wasn't put into execution properly. And
I would say it's the execution is my guess, because there is a very popular tactic, which is just scream and yell till you get what you want. And like I can tell you where I live, there was a slight period where we were green, and a number of the ganenot and teachers come from a red town nearby. And even the parents in the green town where I lived when it was green, they want those teachers to come so that they can go to work, right? And so guess who's red? You know, it's like, well, that did not work so well. Now we're red too. It's just not helpful. I'm still orange, but I promise you in the next hour we'll be red because we're like teetering on the
That
edge
was
there.
my fear when I just told my husband to check the WhatsApp, because I was like, oh God, we've gone orange and we need to figure out how to work in capsules. Okay, we have a question from Judith about masks. I'm hearing my washable homemade masks are not sufficient against new variants, but the surgical masks irritate the skin on my jawline. What should I wear? Are the more expensive masks worth the money? Should we be doubling up? Is washable homemade masks okay after we've been vaccinated? Masks.
Still asking mask questions a year in? Okay.
Well, now, I mean, America, the US is double masking. Are we supposed to be double masking?
This is like I think a 3-ply mask, whatever it's made out of, still does the job, right? What are these layers doing? They're simply kind of like creating almost like a net, I guess you could say, that catches the virus on the outside. And again, if both people are wearing masks, it's really kind of gross, but I really like that image of the person peeing on the other person's leg, right? That one's great. You really understand well with that one. So, you know, if the person who's sick is wearing the mask and correctly, and the other person is, it's really almost foolproof. I have seen quite a few cases in my clinic where unbelievably there was no transmission because of the 2 masks. So I don't see, I'd be curious to hear what Joel, who maybe knows more about the sizes of various viruses and their ability to penetrate masks, but I don't.
So the variants won't change the size. So I don't think size is an issue. That was also one of the original things that I had. You know, these masks are very effective to stop bacteria because of this, the pore size and stuff like that. Viruses, maybe, I mean, the data clearly supports that they do, because it's aerosol. We didn't know at the beginning that it was, you know, little droplets of liquid that the virus was sitting on. So at the beginning, when I thought it was a virus that could get through, then the holes in the mask, it didn't matter and made no difference. But when we learned that it was aerosol, I think I haven't seen any evidence that you need to double mask or whatever because of the variants. I don't know where it's coming from. I don't see a reason for double masking.
Joe brings up a good concept. I just want to reiterate. You brought up, like, by the way, but you should say, you know, people made in the beginning, when people, the now anti-vaxxers, when they were anti-maskers in the beginning, made this correct statement that the viruses are so small they can make it through the weave, the pores of the mask. And the thing is that the viruses don't travel on their own, right? Viruses need to hitch a ride on something. And they hitch a ride on these droplets that are part of your saliva, your aerosols, your breath. What the masks block is what they're hitching a ride on, right? The viruses are small enough to make it through, but the the vehicle that they're hitching with can't make it through the masks. And that is true whether it's paper or whether it's cloth. The only reason that the N95s I think are so much better is because people who wear them correctly and know to create a seal, they really sealed all the way around, and that's the difference. I think my biggest peeve is when I see people wearing the N95s only on their mouth, and then I'm like, oh, you got the good mask, but you still put it on your mouth only. Like the value of it is the seal that it creates. So
just a practical piece of practical advice to the person who asked the question. I ordered some masks off of our favorite website, AliExpress, and of course they came from China. And they had this nice feature that they were cloth, so they're comfortable, and inside you could put in another layer that's disposable. So you're really getting the best from both worlds.
Great. So I'll ask one more question from Judith, and then Taylor, you can ask Michael's questions. How can we best protect our kids? You know, I'm adding this because I know what the answer is, but we are all feeling a little homesick or like pre-homesick. How can we best protect our kids if we do decide to get on an airplane?
I read an article about airplanes having a lot of air circulation, actually. And it is a confined space, but keep in mind that they need to essentially pressurize air and make sure that it's circulating. Otherwise, people that are at 30,000 feet will not breathe. And there are filtration devices that are there. So
I'm laughing because I gave a similar talk 2 weeks ago to a group in Netanya, mostly pensioners over the age of 70, and the title of the talk was Vaccine, Facts and Fiction. They never asked any questions about that. They all had their vaccine. They were like, when can we hug our grandchildren? When can we go out? When can we go on a cruise? And when can we go on a flight, right? And I was blown away. There wasn't a single, nobody had a doubt about the vaccine. They all wanted to get back to their normal lives. They were like, we're 70. We might not be alive next year. I want to go on a cruise. And I was like, I hope it's not a cruise to Japan, because that would be a terrible idea. Now, there's not a lot of stuff out there, but Avraham's right. A plane has HEPA filters, which are these really good air filters. And there was an article that I saw saying that an airplane is going to be safer than going to Supersol to do your weekly shop, right? Because of all of the filtration and the air turning around. But there have been cases of mass infection from a super spreader, not because it was on a plane, because there was a super spreader. Now, these people that are super spreaders, they're out there, and they, for whatever reason that nobody knows, will infect everybody around them, right? So if you're sitting in a closed aeroplane on a flight to New York or Johannesburg or whatever it may be, and one of these guys or people are on there, then, you know, even the best filtration might not help. I think it comes down again to risk benefit, right? So if you remember in the very beginning, last Pesach, just after the whole Purim thing, the lockdown, you would stand in a line to get into the supermarket, and then you would see people put on gloves, and they would put on their mask, and they would take out wet wipes, and they would wipe down the trolley, and then they would wipe down the food and put it in, and they would get home and they would wash the food, and they would wash down. I mean, there's common sense, right? A little bit of common sense. So there is a risk in flying, but people want to get on with their lives, right? So if you've had your 2 shots and you're vaccinated and you're wearing your mask on the flight, because you have to wear your mask on the flight, except for eating and drinking, so you reduce your risk. It's all about reducing your risk. So eventually people are going to want to get back to normal life, whatever that may be, and travel. And I haven't been to a conference, and I don't even know if conferences are ever going to come back again, but, you know, networking and business has to happen, and people will start traveling. And I think we're in a little bit of a bubble. I think in the US, people are traveling for work. People are getting on planes and going from LA to New York and New York to Chicago, and they're going to meetings and they're wearing their masks. And I don't think you've seen cases of these mass spread events out of a flight to Chicago kind of thing.
I think it depends on where they are in the
No.
US.
I think it depends on the bubble that you live in.
Okay, so we have more questions about the vaccine. One's from Michael. He says, how effective is the vaccination for a virus that has caused such a worldwide pandemic where only 30 to 40% of the population are vaccinated?
I'm going to break that down because it's 30 to 40% of the total population. But let's remember, we started out by protecting the elderly population. So if you look at the statistics that come out every day, Misrad has a telegram where the numbers come out every day. Everyone can see them. Over the age of 60, 70, and 80, we're close to 90% of the population that's been vaccinated. So that's almost everybody. That the population average doesn't take into consideration Haredim and Arabs, unfortunately, which have much lower rates of vaccination compared to the Jewish populations in most towns. Now, I'll give another example. Ra'anana and Tel Aviv have got much higher vaccination rates than Netanya. For some reason in Netanya, people are scared. They're not turning out in the numbers. I mean, it's the same as the national average, 36%, but it's not higher than that. So I'm not sure it's fair to use a national average. And it comes back to what I said before. The quicker we get to that critical number, whatever it may be, 60 or 70 or 80% of the population vaccinated, we barrier the virus from jumping. That's what we need to do. We need to stop the virus from jumping. And in that population of over 60, we already see it. If you look at the graphs, the number of positive cases, the number of mild cases, the number of severe cases, the number of hospitalizations, it's going down and down and down and down. They're going to disappear in the over 60s. And as a result of that, the average age is going down and younger people are getting sicker because they're not getting vaccinated.
Thank you. So Michael's next question.
Yeah, just the second part, because the first part we answered.
Yeah, the first part Joel already answered. But basically his question is about if we have to continue getting the vaccine or get revaccinated after a certain amount of time. Of course, you already said that we don't know if it'll last 6 months, 8 months, and we'll have more information as time unfolds. Do you believe that the side effects for receiving multiple doses over a period of time become more dangerous on receiving each new dose?
The answer is no. So the answer is no. I want to, and Noah will help me out in a moment. Let's talk about long-term side effects, the concept of long-term side effects, okay? Because it's around, everyone's talking about it. It's a new technology and then nobody studied long-term side effects. Okay, let's talk about vaccines in general, all of the vaccines that are out there. When you have a reaction, it happens in hours, days, maybe weeks, okay? It doesn't happen months, doesn't happen years after the vaccine, okay? There's lots of vaccines, everyone gets them, kids get them, adults get them. That's on the one hand. On the other hand, every single vaccine that's ever been approved didn't have long-term effects at the time of approval. There is a concept that people haven't caught onto, or the wrong concept that they have caught onto. What happens is there is a minimum amount of data that you need to present to the FDA or the European FDA or the Israeli Misrad Habriut that shows that you have an effect and are safe. And you get approval. And then you are committed by those bodies to do something that's called post-approval studies. Now, that's not just vaccines, that's all drugs. Sometimes they're called phase 4 studies. They're often called post-approval studies. And it's mixed with another word that's called pharmacovigilance. What does that mean? You have to go out and track the larger population that you've studied, because when they did the phase 3 studies, for example, Pfizer and Moderna together had 70,000 people. Now we've got 3 million people in Israel. You've got 55 million people worldwide. They're being tracked for side effects. They're looking now for those rare events that might happen, because when you've got 70,000, if something were to happen in 1 in a million, you're not going to see it in 70,000 people, and you're not going to see it in 100,000 people, and you're not going to see it in 500,000 people, because it only happens in 1 in a million, right? So it is the duty of the pharmaceutical companies and the regulatory bodies to start tracking all of the people that now got the vaccine, and that's true for every vaccine. Post-approval, the purpose is to study over a longer period of time, not for long-term side effects, But is there a rare thing that might happen that we will happen as a result of the fact that we have many more people out there being vaccinated? And can we learn from that? And I'm going to give an example. So Gardasil, the vaccines for papillomavirus, when they first got approval, the rollout started to happen, and we've now got 15, 20 years, depending on which vaccine and which country, but at least, you know, a good 10 years of data. And you had to reach a certain number of vaccinated people for something to pop up that happened and was very alarming and got studied and is now considered as a population that should not get the vaccine. And what do I mean by that? Somebody noticed that in teenage girls, they got a terrible reaction to the vaccine. And it turned out that all of them had a form of lupus, an autoimmune disease that nobody, either they knew about or they didn't know about. And their underlying autoimmune disease made them have a much worse reaction to the vaccine. So now there's a black box on the label, and girls that have autoimmune disease or suspected autoimmune disease don't get the vaccine, or if they get it under supervision. And they only knew that because of a post-approval safety studies that looked out for much longer times in much more people. So there is no concept of an approved vaccine with long-term effects. It doesn't exist. It happens post-approval, always. This is not unique to Corona, COVID, and Pfizer, Moderna.
Well, I think his question might have been referring to the fact that when you get the first dose of the vaccine, typically it has less side effects or less severe side effects than the second dose. Maybe he was worried that there's a cumulative effect of if you get annual, then you end up with worse side effects every year. So answer that one. But I mean, that answer is also no, but you can explain the science on that one.
All right, so sorry about that one. So the answer is also
That's okay,
no.
it's good information.
The answer is no. So Noah can jump in because she actually wrote a really nice post about a reaction. So there is no correlation or association between having a bad effect the first time and you'll get it worse the second time, or if you didn't have it the first time, you won't have it, you will have it the second time. And there's also no association with the amount of immunity that you developed, right? So people have reactions. Are those reactions real? Yes, they are. Are they caused by the vaccine? Sometimes. Are they caused psychosomatically or from the stress or whatever? Sometimes. Will they necessarily be worse the second time? No. Are there people that have no reaction both times? Yes. If you look at them Stratabriot, and I can put up the link on the Facebook page later, you can go in every 2 weeks now to have a report of the tracking of side effects. And you can look at the graphs because they're comparing a certain side effect, let's say pain in your arm, between the first and the second. Does it go up? Not particularly. Out of 3 million people, we're talking a few thousands that are reported, not necessarily had and didn't report, but reported a particular side effect. And you can look at the graphs because they're color coded for first and second. They're not particularly different. But the more important thing is if 3 million people got the first one and I don't know, let's say 30,000 reported an effect, that means, God, I have to do the math, 2,900,000 and 930,000 or 70,000 or whatever it may be, didn't have an effect. Does that mean they didn't have antibodies and the people who had a thing had them? No, everyone's got the antibodies, all probably at similar levels. So there's no relationship. And therefore, to answer the question, and I rambled on a little bit, I don't see any reason why if you got a yearly shot, it would be worse. And in fact, we know that from flu shots, right? 1 year I had a flu shot and I felt like crap for 3 days. This year I had a flu shot. I didn't even feel anything in my arm. I mean, nothing. I think there's a lot of noise, a lot of variability.
It's funny because I understood the question a third way, which was looking at it as a chemist. There are other ingredients that are in this vaccine as well. You're getting 0.3 mLs, right, Noah, of this liquid formulation. And there's an active ingredient, but there are all sorts of other ingredients. And people On forums, people ask us questions about the other ingredients, and someone asked, what is this potassium chloride? I see it's in the list of ingredients. If that's dangerous, what's potassium chloride? And my answer was, if I may share a screen for a second, was as follows. If the host, Taylor, are you the host? Can you enable that? Or yeah.
What do you want me to do? Allow you to
Just
share?
allow me to share screens, because I think the visual is important here.
Ooh. How can I allow you to share? Spotlight, make host, remove.
Oh,
There's screen the bottom, and then there's an option for other participants to share screen.
So is there accumulation of these other ingredients that are in there? Because you're getting a lot. You're getting, rather than having a small amount, you're getting a lot. And we've had questions regarding a number of the ingredients. So here is just a quick Google search. I came up with, do you guys see it?
It's coming up, yeah.
Okay, so there's this bottle here. It's called Melach Haaretz Mufchat Natran. People who want low sodium salt and are on low sodium diets, they take potassium chloride. They sell it in supermarkets. I don't know if you guys have seen it. It's a big bottle. You put it on your food. You eat lots of this. There may be long chemical names to these things, but that doesn't mean that they're bad for you. There's no correlation between the size of the name, of the chemical name of a substance, and its impact on your health. And I've seen, in fact, a nice graphic on this that shows a long list of ingredients of various chemicals that most people wouldn't identify. And then there's a picture of an apple. Those are the chemicals that are within an apple. So I hope that answers the questions. I hope one of our answers at least answers the question.
One of our answers was the right one.
Okay, so we have all been together for an hour and a half already. I think everyone gets the opportunity to turn off their brain a little bit, since we know our brains are working extra hard. Natasha, we answered the question already, so just make sure to check back when the recording is posted so that you can get that answer. I would love for each of you to give your prediction on where we're going. Let's say in the next 6 months or the next year.